spine board meeting about how I do it. And I want to say hello to all friends and all participant, audience, and whoever's come to see Professor Kim talk at this session. And maybe because it's time now, Professor Hyung Sung Kim, my dear friend,
Okay,
maybe you can start now, please.
okay, okay. Can you see my slide?
Yes, 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 we can see.
Okay, okay. Good morning, good afternoon, good evening, everyone. I'm Hyunsung Harrison Kim from Harrison Spin Arthurs Hospital, Cheongdam, South Korea. And it is my great honor to give a talk in the World Spine. So how I do it session. Currently I'm a president of Korean Minimally Invasive Spine Surgery and Surgery Society and editor in chief of Journal of Minimally Invasive Spine Surgery and Techniques. Today my talk is the uniportal endoscopic and or spinoscopic decompression for degenerative spinal stenosis. Yes, we nowadays we know that there's some endoscopic spinal surgery. We name the spinoscopy. Endoscopic spinal surgery developed so much, and the endoscopic decompression is common in for the degenerative spinal stenosis. This is my curriculum right and disclosure. Yes, yeah. Now, the endoscopic spine surgery firstly started from disectomy, but now going on the fusion generation. And we know the generation changed from the endoscopic transform disectomy of the first generation and second generation of the intravenous disectomy. But after then, move to the endoscope decompression, and for third generation, and fourth generation, and those endoscope fusion generation. After rising the some endoscope decompression generation of the third generation, the endoscopic spine surgery developed so much and expanded so much, and then the in this my paper talking that some using the endoscope decompression and fusion, the all for degenerative spinal disease can treated by the endoscopically. That meaning that the can give the more good clinical result to the patient. But before, at the initial stage, the many doctors some worry that what is the advantage of the endoscope decompression. But currently, we know that truly know that the advantage is that it is a more see the more deeper point and a more clear point with water irrigation and also more mobilized to the target point and working channel. Then there is more advantage compared to the open surgery. In spite of that, the tubular decompression and endoscopic decompression have a more good advantage like that. And you can see the in spite of the contralateral side, we can see the more deeply, more clearly for the pathology and the compression is possible. And also some another more important rationale is that you can see here this 1 day after operation, severe decompression was solved by the endoscopically clearly. Not only the point there also you can see the bilateral facet preserved completely and also preserve the paraspinal muscle, preserve the completely. That meaning that truly can save the all functional structures, stability structures in spite of the sufficient neural decompression. That is a real rationale of the endoscopic decompression. And also, at the starting the endoscopic decompression, we should know that some anatomical consideration of the endoscopic lumbar area, and we know that in the endoscopic decompression mainly there's some ligament problem, and also we know that there's some ligament problem divided to outer layer and inner layer. But in the main point is inner layer because of that. Uh, Sufficiently detach of the cranial point and caudal point of the inner point is the main point of endoscopic decompression. not only lumbar but also thoracic and cervical OR is this is very important point is that because we naming this point is that some outside in approach and uh, and that point is that the sufficient resection of the cranial and caudal point. And also during the operation, you can see this image and in the endoscope view, but you see in the docking point for, we also can possible upper lamina and some doctors operate to the lower lamina. I like this lower lamina more deeper point because of that this more clear to control the breathing is more good, and also sublaminar drilling can preserve the sufficient facet is possible. And I like this B point. And also in the during in the operation, we can see like this image of the I naming this three V point. You can see the ipsilateral facet area of the made by the inferior articular process, and lamina looks like a V shape, and it naming V point, and also cranial midline also see the uh, ipsilateral and contralateral ligament flavum and the cranial tip making the V point, and also caudal point also ipsilateral and contralateral ligament flavum midline point making the V point. If we detect this point, we can see here is a midline, and we can over the contralateral side is the indication for over the contralateral side. In the technically, the endoscopic decompression, firstly, tried so many doctors, but usually that time is some incomplete decompression or partial resection of ligament flavum only. But after development of the contralateral approach, intraluminal approach, this is my paper, then we know that it is possible to decompression of the ipsilateral and contralateral side together is possible. Then we try the ipsilateral and contralateral decompression using the over the top outside in approach technique. This is very important. And then finally, we can approach to the contralateral, not only ipsilateral, but also contralateral foramen and extra foramen is possible. This naming intraluminal contralateral uh, foraminotomy, lumbar foraminotomy. Then we can go to the near all point of the decompression from ipsilateral to contralateral cranial root and caudal root, and contralateral foramen, extra foramen is all possible. But I already mentioned that if we doing this process more safely, and we try to the thoracic and cervical safely, we should keep in mind that some using the over the top approach. You can see this technique in my paper, and yet yes, we know that in the at the initial time under the top approach is that this under the top approach being that the firstly cutting the ligament flavum, then uh, uh, like this on the cutting ligament flavum and resect around the structures, and inside of meaning that from in and to outside, but over the top meaning that some only drilling the outer layer lamina point and go to the over the top area. This also together outside in from outer to inner ligament flavum takeout, that is over the top outside in approach. Then we can make it butterfly resection of the ligament flavum. This is very important technical tips of the endoscope decompression, not only lumbar but also thoracic and cervical. Or if we making like this butterfly resection, that means that the complete resection decompression is already done. Like this is mainly can possible over the top outside in technique. And you can see like this very severe stenosis cases with using the butterfly resection after operation, the decompression made sufficiently. And also some this four-level, in spite of four-level decompression using this contralateral over top outside in technique, you can see decompression, sorry, this pre-OPM, post-OP, and also you can see this two skins only and operation time also only 48 millimeter for four level decompression. In the technically, not only lumbar area but also thoracic area and cervical area also can apply using this technique, same technique. This thoracic paper already published in the operative neurosurgery, and also this cervical my paper will publish it this year in the JNS. And also, this is my paper is that some same over the top on block resection technique, like a same technique in the lumbar area. And also, I already mentioned that firstly drilling the outer layer point, then take out the ligamentum flavum by the finally, and like some butterfly resection, and the first operative decompression can do the safely. And the circle also same method using the outside in over the top on block section. For example, you can see the ligament problem in the cervical area looks like this figure. But it means that we drill this area firstly, like this shape, then finally detach the ligament flavum and take out the ligament flavum by the one piece, then you can see this configuration can possible. This is very important is that some safely decompression in the cervical area you can do in the future. But this is very important is that some sufficiently preservation of the structure is possible, and it means that the instability not happen. It means that some additional implantation is not needed in spite of the severe myelopathy. Biomechanically, during last 10 years, endoscopic decompression developed so much, and during so much many research is talking that some endoscopic decompression can preserve the facet sufficiently, aiming that minimize the damage and maximize the decompression is possible. In my paper also talking like that. And also some another advantage that some in the not only lumbar area but also thoracic cervical area, especially characteristically this area this bone remodeling made very very good. You can see this is first decompression looks like total resection facet, but after 2 years later you can see all reconstructed here completely. It means that in spite of the sufficient decompression of cervical thoracic area, the instability usually not happen, but also remodeling also made very good. And also, due to these characteristics, in spite of some spondylolisthesis instability cases, in my another paper talking that in spite of the instability, there have no aggravation of the instability usually not happen after during sufficient decompression. You can see this also. Patient 1 year follow-up, the instability not aggravated, the spondylolisthesis not aggravated. Oh. And also in the for preparation of the endoscope decompression, you can see here the you need some firstly need some large endoscope system. Second thing is a good drill system is basically needed, and a good soft tissue manipulation or radio frequency ablation system then needed for soft tissue manipulation. This operating room setup basically collecting the fluid irrigation fluid collected to here, and then doing the operation. And also, I already mentioned that I always do the some over the top outside in technique, not only lumbar but also thoracic, but also cervical. Always this approach use on one technique using or the spine area. And you can see this drilling from cranial, caudal, and contralateral, caudal, and cranial. And finally, take out the ligament flavum. It also same technique from ipsilateral to contralateral, and finally can go to the contralateral foramen. Extra foramen is possible. You can see this old video from this ipsilateral drilling. Outer layer of the ligament from takeout of the ipsilateral side, and the contralateral outer layer of the ligament from takeout, and cutting the ipsilateral cranial ligament from detachment of cranial caudal, and final take out the detach the contralateral side of the ligament, sorry, from here, then finally take out the ligament from like this, and this final step. I will show the illustration. Firstly, skinsion, serial dilation, and drilling cranial caudal ipsilateral contralateral together, and the final take out the ligament from like this way. So one another video showing that you can see this video in the neurospine. Operating room setup and serial dilation, and drilling of the ipsilateral and contralateral uh, bone structures, for only bone structure drilling, and detach the ligament from here. Now going to the contralateral side. You can see this video in the Neurospine Journal of Neurospine Journal. Here the Neurospine. And the final take out the ligament from the ipsilateral and contralateral side. You can see after operation. Yeah. Then it's the same method of over the top outside in approach. There have neither checking the three V points and detach the cranial ligament flavum and caudal ligament flavum and sublaminar drilling to preserve the bone structures, and sometimes channeling channel or channel switching technique using, then you can do the decompression. This is an illustration of the thoracic decompression. It's the same method of the lumbar area like this. And also thoracic area also can sometimes single decompression, bilateral separate decompression, bilateral two level single decompression can possible. Also cervical also same like this method. This cervical area also can sometimes single decompression, sometimes bilateral two level separate decompression, two level single on well, one block decompression is possible. This a sample of the decompression of cervical and this thorax decompression, you can see pre and post. And also butterfly resection from lumbar, thoracic, and cervical. This three-level decompression, 3, 4, 4, 5, 5, 6, using the some en bloc takeout resection technique. I show the cases of the several cases. This L2, 3, 3, 4, two-level decompression cases and pre and post-OP. This is very simple. This is 8-year-old, very severe cases also using the outside-in technique. This is very simple. So many doctors, beginners, they worry that looks like this is not indication of the endoscope decompression, but there is not indication of the inside-out technique. Outside-in technique is no problem. Using this outside-in, using like this technique, like you can see, the compression is possible. And also this case is combined with the decompression and dissecting together, and finally change the small channel and the disc resection together, and after operation, you can see. And also this case is three-level decompression with a very uh, severe osteopathic change and after operation. This decompression is sufficiently can possible using the outside in over the top technique. And also this process is also very simple because of the if we approach to the contralateral side, this in spite of this facet cyst can resect very sufficiently and this post-operative image. And this four-level decompression cases after operation. And this case need a central decompression foraminal, extraforaminal decompression by the one stage is possible using like this. From decompression and change the small scope, contralateral decompression like this, and go to the extraforamen, then you can post OP and this 1 year, 2 year follow-up is sufficiently decompression possible. And this storage case is also using the outside novel type technique. You can see like this case. So OPL cases, post-operative, you can see. Actually, this case is very young patient, but with the symptom, finally you can see this severe osteophyte here. These all bone structures using this only through this outer layer area, then take out the bony osteophyte. Yeah, this contractor side. Then finally, sorry, take out like this. And finally, remove the osteopathic bone structures. Then find this post-op image. Post-op and the 2 year follow, no problem. This patient also 83-year-old patient with uh, uh, paralysis patient after operation. The patient what you can say resolved so much. And this case is combined pathology of the stenosis with the disc. This patient also came with some analgic um, pa- uh, predicate, and after decompression with a large scope and change the shifting the small scope and discectomy doing together by the intramural approach, then postoperative you can see the patient autoimmune recovered also earlier completely nowadays. This another case is very young patient with near project state with this cold damage. And this cases you can see the myelopathy with the stenosis and disc calcified disc together. Firstly, decompression posterior part, and then ventral part also change the small scope, and then this. Uh, oh, sorry. Okay, this also drilled by the small scope, and after operation you can see sufficient decompression, and the patient motor recovered so much, and 1 year follow-up. This patient, you can see the some dramatically improvement after operation. This uh, cold damage 1 day after endoscope decompression, 1 day, 2 day, 3 day, this and 4 day. The patient walking is self-walking is possible. And also subcal decompression doing the same method. And I already mentioned that the separate decompression like this way. In the cases, some mild stance cases, I'm doing like this separation decompression. But in the severe cases, I'm doing the one block decompression. This patient need some sufficient decompression for myelopathy after operation using the outside in over the top technique. And then this another case, two other cases. Then this patient also came to me with the paralysis, and I'm doing the sufficient decompression by the two level by the one piece, and after operation you can see. And another cases of the cervical myelopathy cases also single level decompression. You can see like this sufficient laminotomy was done. And 6 months later, you can see the compression is sufficiently done now. This another case is severe stenosis with myelopathy with weakness patient, and after operation, you can see the sufficient decompression is possible. The patient would also improve so much. This another case is chronic myelopathic patient with mild weakness, and after operation, you can see using the outside in over the top by the one block resection. Then 2 years, 1 years later, you can see decompression sufficiently doing and no aggravation of instability and kyphosis. Usually, endoscope cervical myelopathy, endoscope decompression not aggravated the kyphosis because of that. They need not to plate and some another instrumentation. This another case is 3 level myelopathy patient with weakness. And you can see the eye insert drains so much due to the postoperative hematoma sometimes make some weakness. But anyway, this patient also insert 4 or 5 drain, and after operation, 3 level decompression. And then after 1 year, you can see sufficient decompression still. Uh, and the patient return to normal. Uh, so many of my patients, like this patient also, weakness, they return to normal status after operation. This patient also, this another patient, you can see this 3, 4, 4, 5 very higher level cervical myelopathy. In spite of that, using this outside in over tap technique, we can do the safe operation by the one blood resection post-operative. This patient also, the nowadays the patient return to normal life. This another case is weakness 5, 6, 6, 7 maybe, and the patient came with so severe some plagic status, walking disturbance so severe. But after operation, you can see decompression sufficiently. You can see that some wide decompression was done using the outside and over top umbilical resection. And 6 months later, you can see decompression still sufficiently. The patient because recover near completely nowadays. The patient returned to his normal life. Also, another case is forever, the very severe case also can possible. Like this case is very dangerous, not only endoscopy, but also open surgery. But any kind of operation, you can, this case is very dangerous. But using the endoscope decompression, we can possible self decompression this for this patient using the outside and over the top approach. You can see pre-op and post-op. The patient also improved so much after operation. In conclusion, is that some yeah nowadays all kind of degenerative spinal cells can made by the endoscopically using the and I recommend that over the top outside in approach keep this technique to give the self operation to the spinal degenerative spinal stems not only lumbar but also thoracic and cervical area. I interested this year, November, I will uh, have the International Symposium of Endoscopic Spinal Surgery as a president of Korean Minimal Invasive Spinal Surgery, COMIS president. We know
Yeah.
that some using this decompression
Mm.
and fusion development after that, you can give the all kind of degenerative disease by the endoscopically. In my clinic, the open surgery, we perform about 2,000 cases of endoscopic spinal surgery in my clinic. Among them, the open surgery yearly maybe about 10 or about 10 cases for open surgery. It means that all degenerative can managed by the endoscopically. Thank you so much for your kind attention.
Thank you so much, Professor Kim, and great presentation as always. First, we are now in a question session for the participant, all friends. Is there any question or comment, or maybe we want to share a case for Professor Kim, please?
What?
No, I'm asking the audience to
Mm,
maybe there is there any question?
uh,
Not yet. Yeah.
really, how about some
Yes.
The cervical myopathy, I think that in the cervical myopathy, cervical pathology, the endoscopic spinal surgery is very, very advantage compared to the open surgery. But I'm do the cervical decompression and discectomy every month, more than 20 cases, and all patients have a very happy and very good result without plate, only decompression, only discectomy. What do you
Posterior
think about?
approaches.
Yeah.
Yeah. I think if we can do that by endoscopy posteriorly and then do the compression without any cage or any I mean any stuff to be put inside like implant, it's better. I think it's very good thing to do because nowadays somehow we can see the complication of the cage and the other implant is it's getting higher now in our country. Also in Indonesia there is the complication of the implant is much higher. So if we can reduce the using of implant by doing endoscopy, I think it's very nice, it's very good. That's why
Okay. Dr. Fatos Olda, she questioned that what is the priority of posterior approach to anterior approach? Yeah. Uh, Yeah, at the initial time of the cervical endoscopic approach, I'm also thinking about the anterior approach and posterior approach. At that time, we cannot possibly decompression sufficiently because there at that time have no good drill and no good RF system. Because of that anterior approach, at that time the anterior approach is a good technique. Because of that. That time the indication only discectomy, but nowadays we apply to the not only discectomy but also decompression or so many kind of pathology in the cervical area by the endoscopically. In that situation, I love the posterior approach more good, in spite of the discectomy. Using you know that there's some partial pediculotomy and partial vertebrotomy technique is my technique. Using that technique, we can manage the all kind of foreign pathology by the endoscope posterior approach, not anterior approach. Anterior approach. It means that not only the posterior approach we can operation same or more high quality of operation to the patient compared to the anterior approach. But in the anterior approach, we know that there is sometimes danger to the fairly disaster complication in the anterior approach. Also, that have a two a worry. My worry is that because of that, I'm not tried the anterior approach due to these two worry. One is some uh, uh, very disaster complication like carotid and esophagus and some major complication. And also, second problem is that the point is that the indication is only ventral decompression. Posterior decompression is not possible. Uh, and also using that approach, making the some damage to the disc area, then making the kyphosis aggravation is possible. That's my worry. Because of that, I choose the posterior approach. Uh, Shah, Dr. Shahan Parvin asking about the hello, sir, but failure rate of MS is also very high. I can notice here. Please share your valuable opinion on that. Yeah, actually, we know that some learning curve of the minimal invasive spine surgery and endoscopic spine surgery is very steep, and also uh, like a comment of the Dr. Shahan, the failure rate also very higher in the cases of the some learning curve is not overcome doctors. I mean that I already doing the endoscopic compression spinal surgery of more than 25 years, and I have so many experience. Compared to the open surgery currently, I uh, uh, definitely talking that some endoscopic operation is more advantage to the open surgery and the less failure rate compared to the open surgery. Currently, it means that some the failure rate is not related to the MIS or endoscopic spine surgery. There is your learning status. That's the main problem. And also, Chemin, Chen, Chen, how to prevent complication for endoscopy, multi-level cervical decompression, especially for severe stenosis and myelopathy? Yeah, that I already mentioned that some uh, over the top outside in technique, keeping that is very, very important. Only drilling the ore structures finally take out the ligament problem. Chen already visited my clinic and maybe see the some cases of cervical decompression. I'm doing the so many cervical decompression with the myelopathy cases. I think that maybe during 2 years, about more, I'm doing about 100 cases cervical myelopathy with some cold damage patient. The patient all recovered very, very good. Then main point is that keep the over the top outside in technique. Chairman Chen give the two question is that second question is oh, oh, same question. Yeah. Chidem, what do you think
Yeah,
that
achieve
to
them.
use Yeah. What do you think that to use navigation-based endoscopic decompression for spinal stenosis is it effective? Yeah, very effective for beginner. Uh, for beginner, uh, uh, not overcome the learning curve and the status of now going on the learning curve is that some 2 points is that some technical uh, technically it's now overcome the learning curve. And second point is that uh, anatomically not consider the operating video completely. There is a 2 point is uh, the status of learning status. Because of that, some overcome the problem by the navigation. Navigation can overcome the some anatomical point that can more easy to overcome the learning curve. Uh, Okay, oral question is finished. Yeah,
Yeah, I think it's finished. You explained very fast. So, how you do the selection of the patient? If it's multi-level, like this multiple stenosis in the cervical, and how can
yeah.
you decide? Yeah,
Really,
this
you
is
know
it's
that
so much
some,
question about this.
yeah, yeah. In the lumbar area, the only selection is that some in need of decompression, in need of fusion, not selected the open or endoscopy, but only choosing the some in need of fusion or in need of
No, I
decompression.
mean choosing the technique, which one to decompress. Yeah, it's about only endoscopy, but which your priority, because we know that in spondylosis
Only
case,
decompression.
there's also yeah, yeah,
Only
yeah.
decompression in lumbar area. But thoracic area also only decompression. Because of that, it can possible posterior. Sometimes some transforaminal approach decompression is possible because it can manage the oral. Only choosing the some open surgery is that some cervical myelopathy is acute huge disc in the ventral part. Only that cases. That case is usually less than 1 or 2 cases every year. Not so many. In that case, you choose the open surgery. Severe myelopathy, cold injury with the ventral part.
So
Another or is
it's
an endoscope.
yeah, it's
Yeah.
only decompression. And how many cases you do it only decompression? I mean, with static cases. In the static cases, do you still do
Rhesus
only
cases.
decompression? Or yes, yes, stenosis with
Yeah, but,
listhesis.
yeah.
What?
Yeah, at the initial time, I'm already published the paper, and I'm also at the initial time, I'm also very interested that some spondylolisthesis cases can aggravation or not aggravation, but because of at the initial time, I'm checking the cases, but now I did not checking the cases. number of the cases. I think that maybe I'm doing more than several hundred cases of spondylolisthesis cases, but no aggravation. But in the cases of more than grade two, and in the situation, recommend the fusion, endoscope fusion. Mm.
Okay, for the participant audience, is there any question you can ask in chat? Because we have still have time. Mr. Imad, do we have time now? How many minutes we still have? Imad?
Imad,
Kim, you look still the same. No change at all. Or maybe you
Imad,
look younger. Yeah, there's a. Is there any? No, no, there is no
no
another
question.
question in chat.
Dr. Shahan talking that thank you so much, sir. I'm a resident from Bangladesh. I wish I can join the workshop. Okay. Okay.
Okay. I think yeah. Kim.
Yeah. Currently, my feeling is that some maybe the 2.2 of the endoscopic spine surgery has a very big advantage compared to the open surgery. First is that some fusion, lumbar fusion, and second point is cervical approach. Or cervical and thoracic approach because of that I already mentioned lumbar fusion. Currently, the result of the clinical result and data showing that there's some restoration is a near complete restoration is possible by the only endoscopically. It means that in the future there have no indication of the anterior approach. Anterior approach usually need some for insert a big kg and some uh, making the road, correcting the alignment. That is possible by the posteriorly, by the endoscopically. And the cervical also very big advantage that I showed so many cases. Usually, the cases shown today is that need some posterior decompression with the plate or anterior multi-level corpectomy cases. But there is no additional instrumentation and additionally, the patient no aggravation of kyphosis rather than the patient return to normal life. Completely different. Yeah. Haven't
Imad.
have a
Uh, do we have
any
a quiz for this? No.
Sorry, sir?
Do we have a quiz, a world span quiz like always? No, for this
No,
session. Oh
no,
no.
no, no, no.
Okay. So only it's not this. Only
Yeah, this
discussion
is
with
how I do
Professor
it
Kim.
session. So there is just a
Yes. Yes.
presentation.
Okay.
Yeah.
Okay. Uh, do we have still have time now?
I request
Uh,
from 30 minutes. In
30 minutes.
over 30
Okay. So
minutes.
it's over 30 minutes. Yeah, because it's very good presentation, Kim, like always. And I think it is time to end the session, Iman.
yes, sir. We can close the session.
Oh, okay, okay. So, Professor Kim, like always, your presentation is very good and it's inspire everybody here and including me. So we will close this session. Thank you so much for the presentation, and we can meet again in the next World Spine Board. How I do it next time. Okay, thank you. Bye bye, everybody.
Okay. See you.
See you, Kim. See you, Kim. See
Thank
you
you,
soon.
Dr. Kemanuli.
Thank
Thank
you.
you.
Yeah, thank you. Check them and everybody. Imad.